Good afternoon, everyone. Bancroft Neurorehab welcomes you to our Heads Up webinar series. For those of you unfamiliar with Bancroft Neurorehab, we are a premier provider of post-acute neurological rehabilitation, offering residential and day services, neuropsychology, and outpatient services at 3 locations throughout southern and central New Jersey: Mount Laurel, Plainsboro, and Toms River. Bancroft Neurorehab is a division of Bancroft, a provider of programs and services for people with autism, intellectual disability, and other neurological conditions. Today's program is Addressing Sexual Health After Brain Injury. We'll have time at the end of the presentation for Q&A. And now I will turn the presentation over to today's presenters, Jillian Gordon, occupational therapist, and Emily Lertzman, certified occupational therapist assistant.
Thank you for joining us. My name is Jillian, and I'm joined by Emily. We'll be presenting today on the topic of addressing sexual health after brain injury. We have nothing personal to disclose other than that some of the information provided in this presentation has been adapted from presentations formerly given by our colleagues. We greatly appreciate the permission given to us by Ms. Pino and Dr. Berardinelli to incorporate their work into this presentation. Following this session, you should be able to identify changes in sexual functioning, intimacy, and relationships faced by individuals with brain injury, communicate the role of the rehabilitation team in supporting the sexual health needs of their clients, and describe assessment and treatment strategies to promote sexual health after brain injury. To clarify what we do hope you will gain, I also want to highlight what we are not aiming for. The presentation is not intended to provide specific information regarding reproductive health, sexuality, gender, or details regarding interventions for specific clients. We are planning to address the root causes and examples of the physiological changes that an individual may experience following brain injury and the impact on their sexual health. We also will discuss the role of the rehabilitation team in client education and intervention regarding sexual health. We will include a review of the gaps in current service provision, how professionals can address this area of health, and non-comprehensive examples of goals and interventions. Our focus today is to provide our audience with basic information and resources to develop knowledge and confidence for addressing sexual health with clients and their caregivers. We have a few definitions that we'd like to clarify before we begin. Each will be expanded upon later in the presentation. According to the current definition provided by the World Health Organization, sexual health means a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. As we discuss sexual health in this presentation, we are highlighting information regarding the physical, psychological, and sociological aspects of engagement in sexual acts with partners and self following brain injury. For this presentation, when we use the term brain injury, we are referring to an acquired brain injury. According to the definition provided by the Brain Injury Association of America, acquired brain injury means an injury to the brain that is not hereditary, congenital, degenerative, or induced by birth trauma. The injury results in a change to the brain's neuronal activity, which affects the physical integrity, metabolic activity, and functional ability of nerve cells in the brain. An acquired brain injury may be traumatic, like a fall, assault, or motor vehicle accident, or non-traumatic, such as a stroke, seizures, or tumor. According to the current working definition provided by the World Health Organization, sexual rights means the application of existing human rights to sexuality and sexual health. Sexual rights protects all people's rights to fulfill and express their sexuality and enjoy sexual health with due regard for the rights of others and within a framework of protection against discrimination. Several basic human rights are critical to the realization of sexual health. These include, but are not limited to, the rights to equality and non-discrimination, the right to privacy, the right to decide the number and spacing of one's children, the rights to information as well as education, and the rights to freedom of opinion and expression. Sexual consent capacity has been defined as the ability to voluntarily make a reasoned decision whether or not to engage in sexual activities. Capacity to consent has further been described by Leiden as an adult person has sexual consent capacity if the requisite rationality, knowledge, and voluntariness are present. It is important to remember that requirements vary by state and may include points regarding fully comprehending and exercising rights, including the right to refuse to engage in sexual conduct with others. Finally, we define sexual dysfunction. There are 4 main categories of sexual dysfunction. They include desire disorders, such as sexual aversion or hypoactive sex drive, sexual arousal disorders, including poor lubrication for women or erectile disorders for both men and women, orgasmic disorders, including anorgasmia, the absence of or inability to orgasm, and early or delayed ejaculation or absence of ejaculation, and sexual pain disorders, including vaginismus, which is the body's automatic reaction to fear or penetration, which causes the muscle contraction and pain, or genital pain during or in the absence of sexual intercourse. To be noted, conditions are only considered disorders if they cause distress for those experiencing them. Sexual dysfunction, according to the definition provided by the Cleveland Clinic, means a problem that can happen during any phase of the sexual response cycle. This leads us to the human sexual response cycle. I first wanted to review the typical pattern of reaction during the human sexual response experience, including the physical and emotional changes expected as one engages in sexual interactions with others or during masturbation. During the desire phase, interest and drive increase as the thought or opportunity for sexual interaction becomes apparent. In the arousal or excitement phase, physical changes are occurring to prepare the body for sexual activity. Typically, these changes include a combination or all of the following: increased heart rate, changes in breathing, increased muscle tension, increased blood flow, erection, and lubrication. The plateau phase encompasses the physical activity of sexual engagement, where the physical changes are becoming more intense until the release of sexual tension, known as orgasm or climax. Finally, the body returns to its normal state after climax in the resolution phase. Following a brain injury, individuals may experience disruptions in the human sexual response phases just mentioned. While each brain injury impacts differently, these are examples of changes that may occur. Individuals may experience decreased or absent desire, sexual fixations, or increased drive, decreased arousal and limited physical response, leading to erectile dysfunction or insufficient lubrication, the physical inability to achieve or maintain positions due to lack of strength, coordination, or flexibility, limited endurance, or limited attention skills, difficulty or inability to achieve orgasm, or delays in the calming phase, leading to prolonged arousal and physiological dysregulation. According to a study by Golden et al., approximately 30 to 50% of individuals diagnosed with traumatic brain injury experience difficulty with sexual functioning. These changes include reduced frequency of sexual activity, reduced quality of sex, reduced satisfaction, increased or decreased sex drive, with decreased being more common, difficulties with climax, and changes in sense of self. For example, no longer feeling adequate or desirable. Causes of physiological changes and sexual dysfunction may include injury to various parts of the brain. According to a study by Zarai et al., some studies suggest that lesions in the right cerebral hemisphere cause more significant sexual dysfunction than those in the left, but data is conflicting. Other causes may be neurochemical and hormonal changes, fatigue, medication effects, psychological factors, cognitive decline, and sleep and wake cycle disturbances. Physiological changes will depend on the areas of the brain impacted by brain injury. Limitations will require unique solutions to common problems. An example of this is that impotence must be treated differently if one experiences it due to a lack of attention versus a lack of sensation versus a medication side effect. In the interest of time, I will not read through this entire slide, but I wanted to have the information available for later review in your handouts. I'll highlight a few areas that were lesser known to me in my role as an occupational therapist. Hypogonadism or endocrine disorder is caused by an injury to the hypothalamus and limbic structures. This indicates low or non-functioning sex hormone production and would likely require medication to support more typical functioning to increase sex drive. An irreversible loss of libido is possible after an injury to the basal hypothalamus. This type of change would require problem solving to support outside of the box thinking to identify ways an individual can engage in satisfying sexual interactions considering their lack of drive. Following brain injury, disruptions in intimacy and ability to satisfy sexual needs can be caused by various physical changes. Erectile dysfunction can be both psychogenic, meaning related to thoughts and feelings, or physical in pathology. According to Yang's retrospective cohort study of males in Taiwan who had previously sustained TBI, patients with TBI have a significantly higher risk of developing ED, especially organic or physical ED, than the general population. The age group of 20 to 44 years old had the highest prevalence of ED, and anxiety disorder was also associated with an increased risk of ED. An analysis revealed that the TBI group had significantly higher rates of ED than the control group at the 7-year follow-up period. Various other physical changes can limit sexual functioning as well. These include diminished or heightened sensation, inability to control bowel and bladder, temperature dysregulation, headaches, endocrine dysfunction, limited stamina, coordination impairments, decreased flexibility, limited strength, and increased or decreased tone. Cognition and communication changes also impact sexual functioning. Post-brain injury changes in cognition and processing may limit an individual's ability to navigate both familiar and novel situations. These include impaired memory, limited perspective planning skills, impaired anticipatory awareness, and decreased attention span. Expressive and receptive language, along with social pragmatic skills, may be altered following an acquired brain injury. Communication changes may include impaired expression and ability to clearly communicate needs, desires, and intentions, impaired comprehension and ability to understand others, and limited social interactions. This may result in less successful or less opportunity to engage in social situations that could lead to sexual interactions or meaningful experiences. Psychological and behavioral changes can often be the most difficult to accept and work through after a brain injury. These can negatively impact various areas of a person's functioning, including sexual engagement and intimacy. Psychological changes can impact the way an individual views themselves, others, or situations they encounter. Changes may include mood swings, change in self-esteem, depression, personality changes, or feelings of isolation. Limited self-regulation is commonly noted following brain injury, negatively impacting relationships with others and self. Other behavioral changes include impulsivity, limited self-monitoring, and awareness of the impact of their actions, flattened affect, or delayed reaction. There are various interpersonal considerations following brain injury that may attribute to limited sexual interaction or satisfaction. These include decreased social engagement, changes in roles and responsibilities, emotional and personality changes, caregiver stress, limited time and energy, changes in perception of sex appeal, fear over injury, and caregivers' emotional or psychological reactions to their loved one's brain injury. Considering these factors, it's unsurprising that research has indicated that dependence in activities of daily living increases the risk of sexual disorders. According to a TBI consumer report issued by the Mount Sinai Medical Center, a 2000 study identified that there are significant gender differences regarding the impact of brain injury on sexual functioning. Between 1993 and 1998, the Research and Training Center on Community Integration of People with TBI collected data from individuals who have experienced TBI and consider themselves with a disability, and others in the community who had not sustained a TBI. The participants were from New York State of all backgrounds, ages, and both genders. Women with TBI reported experiencing many more sexual problems and sexual experiences of lesser quality, evidenced by experiencing multiple of the following issues: inadequate energy for sex or painful sex, low sex drive, problems in initiating sex and becoming aroused, inability to masturbate, problems in reaching orgasm and in vaginal lubrication, discomfort in moving about or positioning themselves during sex, less bodily sensation, feelings of being unattractive, and discomfort with having their body seen during sex. While the average woman with TBI reported that between 2 and 3 of these sexual problems, the average woman in the non-TBI group experienced only 0 to 1. For men, the biggest difference between the non-injured group and TBI group were relationship status and frequency of sexual intercourse. Less men with history of TBI were in a meaningful relationship than the non-injured control group, less than 50% compared to about 75%. And less men with a history of TBI engaged in sex in the past year than their peers, about 50% compared to 85%. While quality of sex was also reportedly decreased for men, it is less so than for women, with men reporting 1 to 2 problems versus women reporting at least 2 to 3. For both men and women, those injured later in life expressed more problems than those younger, and depression was consistently correlated with lower satisfaction levels for both men and women. So what happens if we ignore sexual health in rehab? When sexual functioning changes, it can make a person feel more isolated, less confident, and less close to other people. A variety of negative results may occur if we ignore the sexual health needs of our clients. You may encounter inappropriate verbal expression of desires toward others, fractured relationships, engagement in unsafe sexual practices, or increased stress, among others. When addressing ADLs, it's critical to include the forgotten ADL of sex. In addition to increasing self-esteem and improving quality of life, developing comfort in discussing sexual health may increase a client's willingness to seek solutions. Supporting engagement in consensual or personal acts may limit frustration and improve behavior. Identifying needs and appropriate methods to address them may support improved ability to communicate and appropriately engage with others. And improving self-awareness will likely result in increased willingness and ability to participate in interventions to support sexual needs. Dombrowski's 2000 study outlined case studies of 3 individuals with TBI, noting individual differences in skill, knowledge, and behaviors. With education came improved self-awareness for the clients. This resulted in increased willingness to participate in treatment, and tailoring the treatment to their unique needs resulted in an increased ability to receive feedback regarding inappropriate social interactions. It also resulted in improved response to external aids to support appropriate behaviors and improved independence in the community. By improving knowledge and awareness, the success of interventions was noted by improvement in quality of life. Our role as healthcare providers is to support the rights, health, and well-being of our clients, including engagement in intimate relationships, participation in self-expression, and the performance of all self-care acts. This includes discussing sexual concerns with patients. In an effort to provide well-rounded and holistic services, we must consider the physical, emotional, social, spiritual, and economic needs of our clients, along with their response to illness and the effect of their illness on their ability to meet their self-care needs, including their sexual needs. As healthcare professionals, our responsibilities include supporting human rights by providing education and monitoring for infringements, understanding post-brain injury difficulties and expression of sexuality, having a greater knowledge of the difficulties faced by clients will inform our care plan development, clarifying personal values, developing rapport and communication skills, assessing capacity for sexual consent, which you'll learn a bit more about soon, and educating clients to promote informed decision-making. In most healthcare settings, professionals are not addressing sex, intimacy, and personal relationships. A study by Arango Lasparilla et al. In 2017 reviewed the levels of training and attitude of various healthcare professionals on working with TBI patients and guidelines related to sexual issues. This study surveyed healthcare professionals from 22 different countries in regards to the treatment of sexual health and function. The study found that most healthcare professionals agreed that they should encourage and support sexual activity in adults with TBI. The study found that many believe sexual expression, whether it be someone who is cognitively intact or impaired, is healthy and increases quality of life. However, despite 97% agreeing that it should be addressed, only 36% report that they have discussed it with their clients. Participants noted that they do not have access to clear guidelines to determine if someone can consent to sexual activity, and 29% reported discussing it only after their client has brought it up. And regarding the reason for this presentation, the study found that healthcare professionals would have an easier time addressing the topic if they had received additional training and education in this area. So why is our response lacking as healthcare professionals? There are various reasons as to why there is such a low percentage of healthcare professionals addressing sexual health. These include personal embarrassment, lack of knowledge and training, anxiety about sexual topics, a perception that individuals with brain injuries are asexual or hypersexual, and a perception that sex education can lead to increased sexual inappropriateness. But what do our clients say? Individuals with TBI reported low frequency of discussion on topics of sexuality with clinicians, meaning they almost never engage in discussion regarding these topics. However, research has found that most clients are open to discussions and wish healthcare providers had brought them up during their care. According to Moreno's study, individuals with TBIs in his study complained about the lack of openness to questions related to sexual and reproductive health, and that their providers did not ask them actively enough about sexual and reproductive issues. In order to maximize our skills as clinicians, we must develop knowledge and skills to better address the sexual health needs of our clients. Rehabilitation staff need to be proficient in discussing sexual concerns with patients. By gaining a better understanding of post-brain injury difficulties and expression of sexuality, clarifying personal values, developing rapport and communication skills, educating on interventions to support sexual health and engagement, and initiating addressing sexual health in treatment when appropriate.
It is imperative to open the conversation about addressing sexual health, even if it feels uncomfortable. Rehabilitation professionals have a duty to treat the whole patient, including addressing sexual health, as we previously identified that concerns with sexual health after a disability can impact self-esteem and quality of life. Anyone is able to approach this topic. So some tips for professionals include: keep it professional, use technical or formal language, allow the patient to express their issues in a judgment-free way, provide resources, refer out if needed. So some possible professional supports to recommend may include neuropsychology, psychosexual counseling, sex therapists, medical treatment, or support groups. A complete evaluation, including appropriate medical workups to identify all potential factors of difficulty, can be done. There are important factors to consider when assessing sexual functioning, including pre-injury sexual status, cultural factors, relationship factors, cognitive and emotional factors, physiological factors, pre-existing and present illness, and current medications that can affect sexual functioning. And these are some examples of assessments that can be completed: the psychosexual assessment questionnaire, the sexual interest and satisfaction scale, the Derogatis interview for sexual function, and the brain injury sexuality questionnaire. So next we're going to talk about the EX-PLISSIT model. The PLISSIT model was created by Jack Annan in 1976. The EX-PLISSIT model is an expansion of the PLISSIT model by Sally Davis and Bridget Taylor in 2006. This model is used in the field of sexology to determine the different levels of interventions for clients. It is helpful in meeting the sexuality and sexual health care needs of the patient, and it places permission giving at the core of each stage. We can see based off the diagram, the model is cyclical in nature, and this allows for reflection and review after each stage. This also allows the clinician to increase their self-awareness by challenging any assumptions they may have had. Permission giving stage is the first step in addressing the patient's sexual health needs. It provides patients with the opportunity to voice their concerns. It gives the patient permission to feel comfortable about a topic or permission to change their lifestyle or to get medical assistance. The clinician is a non-judgmental listening partner, allowing the patient to discuss matters that would otherwise be too embarrassing for the individual to discuss. It is important to note that when a clinician overcomes their own embarrassment in relation to sexuality, they also give patients permissions not to feel embarrassed. Permission should also be explicit and not vague to avoid any confusion. This stage assists in building rapport with patients, and they will remember they can come to you with any questions or concerns. Examples of dialogue may consist of something like, people with brain injuries often experience sexual difficulties, such as loss of desire or problems with enjoyment. How have you been affected? Or, many people are concerned about how this condition and/or treatment might affect their sexuality. What is your experience? What happens when you and your partner try to make love? How has your health affected you as a couple? Has it affected your sexual relationship? Would you like to talk about this? The next stage is the limited information stage. The patient is supplied with limited and specific information on the topics of discussion. Information about the impact of injury or disability on sexuality and the effects of treatments on sexual functioning should be discussed. Clinicians have the important role of clarifying misinformation, dispelling myths, and giving factual information in a limited manner. Offering too much information at once can be overwhelming for the patient and deter them from approaching the subject again. It can be difficult for them to comprehend and implement any education or information successfully. Some examples of limited information may consist of: some people with muscle spasms or abdominal wounds find some sexual positions more comfortable than others. It is not unusual for people to misinterpret their partners, even after many years together. Talking about how you feel is really helpful. And lastly, it is not uncommon for men or women to be apprehensive about sexual intercourse after having a baby. You may want to explore other ways of showing love and affection or sexual activities other than full intercourse until both feel more comfortable. The specific suggestion stage requires use of a problem-solving approach to address a particular issue. The clinician gives the patient suggestions related to the specific situations and assignments to do in order to help the patient fix the mental or health problem. It may include suggestions on how to deal with sex-related infections or informing on how to better achieve sexual satisfaction by the patient changing their sexual behavior. Some examples include, for hemiplegia, affected persons to lie either on their back or side with the unaffected side uppermost, difficult arthritic stiffness and pain, experiment with different sexual positions and taking pain relievers before sexual activity, muscle spasms interfering with intercourse, you can try different sexual positions, and discomfort or pain in intercourse, use of lubricants, and consider full range of sexual activities. The intensive therapy stage is the most advanced stage of this model. We refer the patient to other mental and medical health professionals that can help them deal with the deeper underlying issues and concerns being expressed. We can refer to sexual dysfunction clinics, psychosexual counseling, sex therapists, or sex surrogate therapy. Some reasons to refer might be if the issue is beyond your competence, if rape or sexual abuse is involved, or if there are relationship problems that warrant marriage or couples counseling. So next we're going to talk about different goal areas. Goals may come from several resources on a rehabilitation team based off evaluations and assessments completed. The following goals are examples provided by licensed clinicians from our Bancroft NeuroRehab's program. Goals may vary depending on the specific needs of each individual. Some psychology goals include: patient will be able to engage in healthy and safe dating practices and be able to verbalize them twice per month. Patient will accept personal responsibility for their own behaviors utilizing I statements weekly for 4 consecutive weeks. Patient will engage in social skill building sessions once per week. Some physical therapy goals include: patient will increase 5 times sit-to-stand score by 5 seconds closer to age-related norms to demonstrate increased lower body strength and stability. Patient will follow home exercise program from printed handout with family training completed as needed. Patient will perform bed mobility required for independence and sexual activity with min assist for safety and stability. And then some occupational therapy goals. Following education, patient will demonstrate working knowledge of adaptive equipment for increased participation in sexual activity on 4 out of 5 trials. To increase safety and independence in ADLs, patient will ID and implement 2 energy conservation strategies with less than 3 verbal cues from the therapist. To demonstrate safe engagement in ADLs and IADLs, patient will tolerate 20 minutes of dynamic functional activity from sitting position, utilizing energy conservation strategies as needed. And lastly, we have some speech therapy goals. Patient will improve vital capacity by sustaining ah for 10 seconds at 70 decibels or greater. Patient will identify appropriate or inappropriate behaviors in themselves and others on 7 out of 10 opportunities. And patient will modify their behavior based on actions of others on 7 out of 10 opportunities. When we talk about improving sexual functioning and satisfaction, as a precaution, it is imperative to educate on safe sex practices, as safe sex is always the #1 priority. That might be birth control or Plan B, emergency contraception, or etc. Have your patient talk to their doctor to ensure they are healthy enough to participate in sexual activity. Consider any secondary conditions and possible complications. Some general suggestions for improving sexual functioning and satisfaction include getting a comprehensive medical examination, arrange a non-distracting environment, minimize fatigue or tiredness, compensate for memory problems, compensate for decreased ability to fantasize or imagine sex, compensate for erectile dysfunction, compensate for female sexual difficulties, psychotherapy, treatment to improve social communication skills, sex therapy, increase opportunities for social interactions, and alternative sexual behaviors. We want our interventions to acknowledge sexuality, provide information, assess needs, teach coping skills, redefine sexuality, maintain safety, and provide resources. Now we are going to address different types of recommendations that may be made. Positioning aids can be used, such as wedges, pillows, or use of a wheelchair. Adaptive equipment can compensate for limited hand function, strength, or flexibility. Modifications may be required to off-the-shelf items to accommodate physical limitations, and training may be required to support the safe and effective use of such products. For example, hygiene or setup of any equipment. An example of an energy conservation strategy would be identifying the time of day the client has more energy to engage in sexual activity. Visual aids can be used for positioning if the client has memory impairments. Reducing external distractions, for example, turning the TV off or ensuring the room is decluttered, can help improve attention. Remediation refers to the restoration of skills such as range of motion, strength, endurance, effective communication, and social engagement as part of meeting sexual needs. Increasing strength and range of motion to improve ability to bear weight through the upper extremities, and simulating social scenarios to reduce anxiety during social situations are two examples. It is also important to discuss and understand rights in sexuality and relationships when addressing sexual health in a healthcare setting. Individuals with brain injury have the same rights as other people to engage in sexual activities and to be sexually fulfilled. Some people with brain injury are more vulnerable to harm by others as a result of physical limitations or decreased cognitive abilities. People have the right to have their sexual needs and preferences accepted and treated with respect. People have the right of privacy and confidentiality in all aspects of their lives, including their personal relationships. People have the right to stop having sex with someone at any time. People have the right to get information they can understand about social relationships and communication skills, sexual matters such as contraception, masturbation, sexual hygiene, pregnancy, and prevention of sexually transmitted infections. Social and legal responsibilities regarding sexual relationships, ways of avoiding sexual exploitation and abuse. And people have the right to say no to things that other people do that make them feel uncomfortable or upset, both physically and sexually. Along with reducing risk, healthcare professionals must also follow local and federal laws regarding sexual health and engagement in sexual acts. Always defer to your own state laws, facility procedures, and legal counsel. The New York State Office of Mental Retardation and Developmental Disabilities Commissioners, a memorandum states that a parent, a legal guardian, or a committee cannot limit an adult person's sexual activity. In Griswold v. Connecticut in 1965, the U.S. Supreme Court affirmed that every person has the right to privacy, to certain forms of sexual conduct, and to make reproductive decisions. The National Guardianship Association Standards of Practice indicated that a guardian shall acknowledge the ward's right to interpersonal relationships and sexual expression. The American Association on Intellectual and Developmental Disabilities asserts that people with mental retardation and related developmental disabilities, like all people, have inherent sexual rights and basic human needs. These rights and needs must be affirmed, defended, and respected. There is a presumption in American law that an individual has the prerequisite capacity to engage in sexual relationships once he or she reaches the age of consent. However, there are consent capacity questions about an individual with cognitive impairments. That can include intellectual disabilities and other conditions such as dementia, traumatic brain injury, and developmental disabilities. Persons who engage in sexual relationships with each other must both be consenting. The capacity to give consent is a state and not a trait, which means it can vary over time. So how does the law define the boundaries of sexual behaviors? In New York, any touching of the sexual or other intimate parts of a person not married to the actor for the purpose of gratifying sexual desire of either party. New York also uses a morality standard. A person must be mentally capable of understanding the social mores of sexual behavior. A person must be capable of understanding the non-criminal penalties that society may impose for conduct it labels as sexually immoral. And New Jersey actually has one of the least restrictive legal standards. It only requires that a person must understand the sexual nature of an act and that a person's decision to engage in sexual behavior is voluntary. There is no requirement that he or she understands the potential risks and consequences of the behavior. Suggested criteria for inferring sexual consent capacity include voluntariness, safety, no exploitation, no abuse, ability to say no, and a socially appropriate time and place. It is important to determine if the individual has the capacity to give consent, and therefore a sexual consent capacity evaluation can be administered by qualified healthcare professionals such as psychiatrists, psychologists, social workers, and physicians. We want to assess the following: rationality, knowledge, and voluntariness. Rationality is the ability to critically evaluate, to weigh the pros and cons, and to make a knowledgeable decision. And within knowledge, we want the individual knowing the specific sexual behaviors in question, choice to accept or reject the sexual behaviors in question, illegality and unpleasant consequences of various specific sexual behaviors, pregnancy and sexually transmitted infection prevention, social and legal constraints on time, place, and context, physical, legal, and ethical responsibilities associated with pregnancy and parenting. And voluntariness is that a person must be able to take self-protective measures against unwanted intrusions, abuse, and exploitation. I'm going to give some example questions from our program sexual consent assessment tool, which is only one component of a comprehensive evaluation. As a brief overview, the assessment is broken down into multiple sections, with each section becoming more specific. After asking the client open-ended questions within a section, the interviewer answers yes or no questions based upon the client's answers. If the answer is no to any of the questions, the assessment is discontinued and the individual does not have the capacity to give consent. They can always be reassessed at a later time. So there is a possibility that after the first section, the test could be discontinued, which means parts 2, 3, 4, and 5 would not even be addressed. So for example, the interviewer will determine, can this person recognize if others have the capacity to say no? So some questions of the assessment include, are there differences between a man and woman's body? If yes, what are they? Do you consider any part of your body a private area? Tell me what parts are private. What does it mean if you try to kiss a friend on the cheek and they pull away? What does being pregnant mean? Do you know of any diseases that you can get from having sex or sharing sex toys with another person? Can you name some of them? If you're on a date and want to have sex, where would you go? Where would you not go? Some sexual behaviors are against the law and a person can get arrested for them. Do you know of any sexual behaviors that can get you arrested? Why do we have these laws? And for voluntariness, does a person have the right to touch your privates if you don't want them to? What would you do in this situation? Would you say something to them? And what would you tell them? So there are other tools that you can also use during this comprehensive evaluation. We have the neuropsychological assessment battery, the judgment orientation subtest, the residential services sexual consent assessment tool, and the wide range achievement test 5 word reading subtest.
So now that you have some information about the importance of addressing sexual health with your clients, we wanted to give you a few examples of how to implement a sexual health program in your own practice. The Disability and Sexual Health Care Competency Model encompasses various ideas of development which support knowledge and skill acquisition prior to application to practice. First, healthcare professionals should develop a critical awareness regarding disability and sexuality. This includes several points. A few of them are taking a critical eye to policies and procedures that are currently in place in your practice setting, providers becoming more aware of our biases about disability and sexuality, understanding disability from a client's perspective, and learning more about physical, cognitive, and social aspects of the disability. Seeking basic knowledge of sexual anatomy and function, normative sexual arousal and response cycles, and common sexual concerns is also important. You also want to be providing education to develop clients' knowledge, which involves initiating conversations, about sexuality and allowing time to explore the topic, including sexual health in clinical assessments and routinely evaluating your own disability and sexuality implicit bias, and matching the language used by the patient to establish and maintain rapport. We suggest using formal and technical language to start, and then try to follow how the client is presenting in order to, again, maintain that rapport with them and make it comfortable for them to be discussing. Developing clinical skills for addressing disability and sexuality would include participation in professional activities that are relevant to the fields of disability studies and sexual health, and increasing competence in conceptualizing assessment results from the disability affirming perspective. Finally, the application of each of these points is the culmination of a well-rounded sexual health program. To give you an example of what a protocol or a formal program would look like, I wanted to present part of our sexual health manual from Bancroft. The purpose of the manual is to provide both clients and staff members with essential information and guidance for the expression of sexuality and in the development of fulfilling social relationships consistent with developmental level, cognitive ability, emotional maturity, interests, and moral beliefs of the individuals that we support. This manual is applied by providing guidelines for how to address sexual health as a part of our services provided to our clients. The manual also serves as a resource for parents, guardians, and other stakeholders. As noted earlier by Emily, ensuring consent and capacity to give it are critical to sexual health programming and intervention. Here's an example of how our social sexual manual identifies someone's ability to provide informed consent to sexual intercourse. The individuals involved are consenting adults. If deemed necessary, they have been assessed by the appropriate clinical staff and deemed to be able to give consent. They meet minimum age requirements as defined by state law. They have demonstrated an understanding of privacy, respecting the rights of others, individual consent, and safer sex practices, and activity is conducted in private and does not infringe on the rights of others. As you can see, these vary by what Emily presented as the state guidelines for New Jersey, but we make sure that we take into account the basic state guidelines and we can expand upon them as a program as we deem fit. The Social Sexual Advisory Committee at Bancroft is a key part of our sexual health programming. The committee meets on a monthly basis or as needed and is responsible for addressing social and/or sexual topics that are not otherwise covered by program interventions. We're able to present complex or concerning cases and receive feedback from the diverse representatives. The committee serves as a resource for staff, individuals, families, guardians, and stakeholders with regard to social sexual topics relating to individuals supported. It's composed of representatives from different service lines and disciplines within the organization and reviews the organization's manual annually, and revisions are made and disseminated through program leadership. In summary, sexual health following acquired brain injury is an under-approached topic in rehab due to a lack of provider knowledge, limited comfort, and personal biases, leaving clients underserved. There are several psychological, physiological, sociological, and circumstantial factors that may contribute to sexual dysfunction and unmet sexual needs for individuals who have experienced acquired brain injuries. Rehabilitation team members have a duty to address sexual health for all clients in order to uphold their rights. Professionals must seek avenues to become more comfortable and willing to initiate sexual health conversations with those in their care, and assessments and models are available to support healthcare professionals in addressing sexual health with their clients. Acknowledging the current gap in service will allow you as a healthcare provider to provide more thoughtful and thorough holistic care. This slide just includes some resources for client education and intervention aids. Thank you for joining us. We hope that you gained information that you can bring back and immediately apply within your healthcare practice. And please feel free to reach out now or later with any questions.
On behalf of Bancroft Neuro Rehab, I would like to thank you for attending the webinar. Have a great afternoon.